Thank you, sir, for the kind introduction, and I would like to thank Chandrasekhar sir for the opportunity. I hope I can do justice to this vast topic that has been given to me over the next 30 minutes. So I'm going to take you through the clinical manifestations of vasculitis, moving from a simple to devastating disease. So what is vasculitis? Vasculitis is a disease process which is characterized by inflammation and damage to the blood vessels, which can eventually produce narrowing and occlusion of the blood vessels. Now, whatever manifestations we see is predominantly as a result of this occlusion or inflammation leading to aneurysms, which causes tissue or end organ damage and leading to the varied spectrum of clinical manifestations based on where and which part of the blood vessel or which organ blood vessel is having vasculitis. It may affect blood vessels that supply many organs simultaneously or can only affect a single organ or tissue. It may be also a primary disease process, or it can be seen as a symptom in another disease, like it can be induced secondary to infections. It can be seen as a part of systemic lupus erythematosus, like how sir has said earlier. So let's look at what a general picture of clinical picture in the entire spectrum of vasculitis would look like. So we commonly see patients with skin rashes, and the skin rashes could be small petechial purpuric rashes in the upper and the lower limbs. It can be maculopapular rash. It can be urticarial rashes, like we can see in the extreme. So urticarial rashes, which can be seen in this image, and we also see patients with punched out bullous lesions or bleb lesions with punched out edges and ulcerating lesions, which can be seen in some type of vasculitis. Other features can be non-erosive arthritis, which is non-deforming. Sometimes patients present with oral ulcers, genital ulcers, which can leave a scar. Fever, malaise and fatigue are usually associated with vasculitis. The organ-specific manifestations are what we are usually worried. It can extend involving the eyes to the skin, the sinuses, the lung, musculoskeletal system, peripheral nervous system. In the eyes, we sometimes see recurrent episcleritis or vital tumors or patient presenting with ulcerative keratitis. In the sinuses, we can have nasal crusting, saddle nose deformity, septal perforations. The lung patients can have hemoptysis or pulmonary alveolar hemorrhage, which can be catastrophic and life-threatening. Cardia, there can be pericarditis and myocarditis. The kidneys, the patient presents with hematuria, proteinuria, and can also have renal failure. So looking at how vasculitis is classified, I think we've all, if we've ever opened the vasculitis chapter, we would see an image which looks like this. The Chapel Hill's classification, where the vasculitis is divided based on the vessel which it is involving. So it is divided into large, then medium vessel and small vessel vasculitis. So based on the involvement of these vessels, we see different spectrum of clinical features, and our treatment plan for each of these conditions, giving due respect to the clinical features which are there, would change from each patient. So looking at the large vessel vasculitis. The large vessel vasculitis, what Indian population we usually see Takayasu arteritis and giant cell arteritis. This is not a very common disease, but these are the two conditions that we come across. So what is Takayasu arteritis? It is a rare form of chronic granulomatous large vessel vasculitis. It presents there is a predominance in females, and it's usually seen in females who are less than 40 years of age. The symptom profile can be very heterogeneous. It can move from an asymptomatic disease to incidentally detected hypertension, which is how most of the patients in India present, to acute onset stroke or cardiac symptoms or cardiac failure. So this progresses from a pulseless phase with non-specific systemic features to vascular inflammatory phase, which rarely ends in a burnt out disease. So most of the patients have constitutional symptoms like fever, but also present with chest discomfort, claudication pain. Based on the area of the large vessel involved, they can have upper limb claudication, lower limb claudication, headaches, shortness of breath. So this is a table I have picked from an article by Danda et al., where they have compared the clinical features of patients in the patients in Indian population as well as Japanese population, as Takayasu arthritis is most widely present in these two populations, and it was noticed that most of them were women. In the Indian population, the presentation was more with hypertension, limb claudication. There was pulselessness or pulse variation, and the most frequently seen presentation was the type 5, that is the type 5 according to the Numanos classification. Other features which were noted arthritis with or without sacroiliitis, oral ulcers. Patients sometimes have associated inflammatory bowel disease, can have episcleritis, uveitis, scleritis, and skin lesions like pyoderma gangrenosum, erythema nodosum may be associated. Moving to giant cell arthritis, this is another granulomatous inflammation which is affecting the large and the medium vessels, which leads to chronic and acute damage, but is seen in the older population. So we have to have suspicion when an older patient comes to us with new onset headache, which can reflect the involvement of the temporal arteries and their branches, which is usually a prototypical manifestation of this condition. They can also have jaw claudication and pain in the tongue, which is usually a rare presentation. Permanent vision loss is something that we are all worried about and that advanced us for aggressive therapy. Constitutional symptoms like fever, weight loss can be associated with these type of vasculitis. So this pictorial representation shows how there can be an involvement of what are the usual areas involved in giant cell arthritis. Moving to medium vessel vasculitis. So medium vessel vasculitis, we have two conditions, polyarthritis nodosa and Kawasaki's disease. I would not be talking about Kawasaki's disease here, I will be only briefly talking about polyarthritis nodosa. So it is a systemic necrotizing vasculitis that predominantly targets the medium-sized arteries. The small vessels, that is the arterioles, capillaries and venules, are not involved. The spectrum can range it involving just a single organ, or it can have polyvisceral failure. So multiple organ involvement can be seen. There can be occlusion or rupture of the inflamed arteries, and this might produce ischemia and hemorrhage, causing organ damage. So what we can see in the pictures, the top shows cutaneous pan, whereas the lower picture is showing a livedoid lesion, which can be seen sometimes associated with this type of vasculitis. It can, patients also have history of weight loss, fever, arthralgia, myalgia, and of course the symptoms which is derived from specific organ damage. So when we look at organ involvement, the peripheral nervous system and the skin usually involved, and here we see patients presenting to us with a wrist drop or a foot drop due to mononeuritis multiplex. Cutaneous features like purpura, livedoid lesions and subcutaneous nodules and necrotic ulcers can be seen. Gastrointestinal involvement, usually the patient presents to the emergency room with acute abdomen because of occlusion of one of the gastric vessels leading to ischemia of the bowel. Renal involvement, there can be tissue infarction or hematoma which is produced from rupture of renal microaneurysms. So these renal microaneurysms is almost pathognomically seen in PAN. It can be clinically silent or it can produce micro or macrohematuria. Hypertension secondary to renal involvement also is commonly seen. Orchitis is again something which we have to have high suspicion for, but is characteristic of PAN. It is due to testicular artery ischemia. Small vessel vasculitis. Small vessel vasculitis can be a little confusing. I think it's this area of interest. So here we have broadly classified them into ANCA-associated vasculitis and immune complex mediated vasculitis. So in ANCA-associated vasculitis, which is an antibody-mediated vasculitis, we have three types, that is granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. So this is an umbrella term for a group of multi-system autoimmune small vessel vasculitis. It can present at any age, and it is GPA or granulomatosis with polyangiitis was initially known as vaginal granulomatosis. EGPA was known as Churg-Strauss disease. They are not called that anymore. They are associated with antibodies, that is anti-neutrophilic cytoplasmic antibodies. Against one is the leukocyte proteinase 3, that is anti-PR3, or the anti-MPO antibody. So here there is an inflammation in the vessel which is induced by the antibody, which can lead to either rupture or occlusion. If there is a rupture and we usually see involvement of the lungs, the skin and the renal, the kidneys. So if there is rupture in the lungs, they present as alveolar hemorrhage. In the skin, it's seen as a purpuric rash. And in the kidneys, if there is occlusion, it leads to segmental glomerular infarction. This leads to individual organ damage and mass effect. Also, we can see granulomas in these areas on biopsy. So GPA, known as vaginal granulomatosis, is a necrotizing vasculitis where we can see inflammation in the vessels as well as perivascular region. It is associated with granuloma formation. Microscopic polyangiitis and vaginal GPA, I have combined them together here because they have very much overlapping features. So it would be easier to explain the features under one umbrella. So here we can see eye involvement, nasal or paranasal sinuses involvement, ear, mouth and larynx can be involved in this type of vasculitis, where the patients can present with nasolacrimal duct obstruction, a pseudotumor, can have nasal hemorrhage, epistaxis, saddle nerve deformity, can have perforation of the nasal septum. They can have multiple oral ulcers which can involve the hard and the soft palate. When involving the lungs, they can present with cavities or bleeds, which we are worried of, lung infiltrates. They can involve the kidneys, causing glomerulonephritis. EGPA, also known as Churg-Strauss previously, is a chronic inflammatory disorder which is characterized by manifestations like asthma, chronic rhinosinusitis, pulmonary involvement and peripheral blood eosinophilia. It's a little difficult to diagnose, so obtaining a biopsy if possible would be useful for the diagnosis. They can also have involvement of the CNS in the form of stroke or CNS vasculitis, and can have other systemic involvement as depicted in the picture. Now moving to immune complex mediated vasculitis. This can be IgA vasculitis, hypocomplementemic urticarial vasculitis, cryoglobulinemic vasculitis and anti-GBM disease. So here there is an immune complex which is developed and it is deposited in the target organ, and this leads to the damage. So IgA vasculitis, I think we all know it as Henoch-Schönlein purpura, involves the small vessels of the joints, kidneys and the GI tract and skin. It can also affect the central nervous system and lungs, but this is fairly rare. So an acute IgA mediated disorder is typically self-limiting and can be managed with mild medications like NSAIDs and supportive care. But if there is involvement of the kidneys or if there is any evidence suggestive of renal failure, it needs aggressive therapy. IgA immune complex is developed in response to an antigen exposure, which gets deposited in the small vessels of skins, joints, kidneys and the GI tract. It leads to release of inflammatory mediators and causes damage like intestinal hemorrhage, palpable purpura and nephritis. It's more commonly seen in children, but we do see these presentations in adults also incited by an infection or some other agent. Cryoglobulinemic vasculitis. These cryoglobulinins are actually antibodies that precipitate at low temperature and dissolve after rewarming. So it refers to the presence of circulating cryoglobulins, and generally this leads to a systemic inflammatory response. There are 3 types, and they can involve the small to medium-sized blood vessels. They are characterized by fatigue, arthralgia, purpura, ulcers, neuropathy, and there are certain conditions that can predispose to this type of a disease, where there can be increased lymphoproliferation, autoimmune diseases, and hepatitis C infection. So what is the pathological mechanisms that is proposed is chronic immune stimulation or lymphoproliferation. This causes the production of high concentration of immunoglobulins, or increased immune complex formation, or insufficient clearance of these cryoglobulins or their immune complexes can lead to this type of vasculitis. Hypocomplementemic urticarial vasculitis. I think earlier when I had shown the photographs of the skin changes, I had shown an urticarial picture which is depicting this. It is a form of autoimmune vasculitis that is characterized by urticaria and persistent hypocomplementemia. This also has a higher incidence in women, and it can present between the 4th to the 5th decade of life. It usually presents with recurrent chronic urticarial rash. They can have angioedema, arthritis, gastrointestinal symptoms like abdominal pain, nausea, vomiting, diarrhea, and also can have ocular inflammation. Pulmonary involvement is seen in about 20 to 50%. Renal involvement is seen in about 50% of the patients. They can have hematuria and subnephrotic range of proteinuria. This disease is usually accompanied by elevated levels of anti-C1q antibody and is closely associated with systemic lupus erythematosus. So most of the times, patient initially presents with this, but eventually is diagnosed with SLE. Anti-GBM disease is a type of small vessel vasculitis which is caused by pathogenic antibodies that target the glomerular and the alveolar capillaries. So these antibodies target the type 4 collagen which is present in the glomerular basement membrane and alveolar basement membrane. I think we all are aware of this condition when involving both the alveolar basement membrane and glomerular basement membrane. It's caused as pulmonary renal syndrome. Patient presents with hemoptysis as well as hematuria. There is limited evidence which is suggesting that all age groups are affected, has a similar disease course. Severe kidney injury can be seen in the manner of an RPGN, and here aggressive treatment is necessary. Patients can present with hemoptysis, cough, dyspnea, and anemia. Other systemic involvements are arthritis, myalgia, but it is fairly uncommon, and if there is presence of these associated symptoms, we also have to think of an overlap of ANCA-associated vasculitis. Behçet's disease is a condition which I have not mentioned in the classification. So these are the three main classification, that is large, medium and small vessel vasculitis. But there are a group of conditions which come under unclassified vasculitis because they can involve any sized vessel. It is an autoinflammatory, so Behçet's disease is one of the examples for these, and it is an autoinflammatory systemic vasculitis of unknown etiology. It is characterized by mucocutaneous manifestations like recurrent oral and genital ulcerations, ocular manifestations like chronic relapsing uveitis, and systemic vasculitis involving arteries and veins of all sizes. The involvement of the pulmonary vessels, formation of pulmonary aneurysms or pulmonary vasculitis is pathognomonic of Behçet's. The clinical features can be oral ulcers, like I said, 97 to 99% of the patients will develop oral ulcers, which usually heal well without scarring. Genital lesions leave a scar, involve the scrotum in males and vulva or in females. In cutaneous lesions, they can present with erythema nodosum and acneiform or pseudofolliculitis. Ocular manifestations, we have panuveitis, which is seen, and retinal involvement also can be seen, which can be a cause for blindness in these patients. This is more so seen in younger patients earlier in the disease. How do we evaluate vasculitis? With the entire spectrum of symptoms and manifestations that we have just spoken about, the history and analysis of the symptoms is very important. So based on the clinical picture, that is the skin rashes, hematuria, hemoptysis and sphincter hemorrhages or ocular symptoms, or whether there is limb claudication, absence of pulses, bruit or aortic dilatation, or nodules, ulcers, pulselessness, gangrene of the digits. Each of these symptoms would guide us to identify and segregate or differentiate our diagnosis into small vessel, medium vessel and large vessel vasculitis. This then further requires blood workup, where we would do a complete blood count, inflammatory markers which are usually elevated. Complete blood count will usually have neutrophilia. Kidney function test may be altered, liver function test. Urine routine, urine protein estimation is done. Viral serology, as we have seen that some of these vasculitis are closely associated with viral positivity like hepatitis C and hepatitis B. Serum cryoglobulin levels, specific antibodies like PR3 ELISA and MPO ELISA is done, or ANA IF with complement levels is done if there is a suspicion of small vessel vasculitis. HRCT or chest X-ray is important if the patient presents with pulmonary manifestations. Biopsy of the involved tissue is extremely essential most of the times for the diagnosis of many of these vasculitis. So doing a temporal artery biopsy or a skin biopsy from the ulcer edge, or doing a renal biopsy if there is renal involvement, which has a very high diagnostic yield. So these are the things which will give us or help us clinch the diagnosis. Also imaging techniques like MR angiograms, CT angiograms and PET CT is now being used for diagnosis of large vessel vasculitis and also to determine the disease activity. Management wise, it is very important that each patient is treated differently. The choice of immunomodulators, biologics and how aggressive we have to be in therapy is totally based on the spectrum of the symptoms as well as what type of vasculitis we are dealing with and the organ involvement. So very similar to how Dr. Chandrasekhar had shown on the slide, that involvement of skin and joints has a milder course, whereas there is involvement of organs requires aggressive therapy. So mainstay of treatment is always corticosteroids to bring down the inflammation quickly, but we overlap it with immunosuppressive drugs like cyclophosphamide, methotrexate, azathioprine. Biological agents are being used like rituximab, tocilizumab and anti-TNF agents. They are more specific and they are target specific, and so we can use it once we identify the proper mechanism behind the vasculitis. Conditions like Henoch-Schönlein purpura, who are presenting only with skin rashes and arthritis, can be managed with supportive therapy and NSAIDs. Involvement of the bowel may require addition of steroids. Conditions that require immediate intervention include giant cell arthritis, if left untreated, can cause blindness. Polyarthritis nodosa, which can lead to organ failure. Vaginous granulomatosis, if involving the lungs and kidney, rapid renal failure or respiratory failure. Renal involvement in IgA vasculitis or HSP, and stroke or severe cardiovascular involvement. All of these conditions required immediate attention and aggressive therapy. So to conclude, as I think the previous two speakers have mentioned, early diagnosis is possible if we have a suspicion, a high level of suspicion, and early diagnosis always helps us to optimize the treatment and achieve remission and favorable outcomes in our treatment. If the time permits, I think I have a few case scenarios that I have only symptoms of. We could discuss it with...
We have another 5 minutes.
Okay, sure. So I'm hoping that I will have some response from the audience here. So I have about 6 cases, but I won't be reading them all. I would just be reading a few of them. So the first one, a 58-year-old female who came with history of episodes of fever, loss of weight and appetite, which was since the past 3 months. She gave history of epistaxis and cough with expectoration. The expectorant was occasionally blood-stained. She also gave history of crusting from the nose. Along with this, she had multiple joint pains which were episodic and mild with minimal swelling, which came and went. So can anybody tell me what they could think of? Anybody who? I heard something. Jerk straws. So I think. Pardon me? Vaginal. So yes, so it is, the patient is actually a case of MPO positive, but she is presented very much like a vaginous granulomatosis or GPA. Here I would say with the history we can think of a small vessel vasculitis, and the symptoms are very classical. Let's look at something else. Okay, 76-year-old female with history of new onset headache with tenderness over the temples and visual disturbances. Yes. Okay, 24-year-old male with bilateral recurrent panuveitis with visual loss in one eye. Has history of oral ulcers and genital ulcers occasionally. Behçet's. Okay. So, 35-year-old female with history of episodes of low-grade fever, loss of appetite, complains of pain in the upper limb, right more than the left, that worsens with activity and improves with rest, pain over the neck and occasional giddiness with visual disturbances. Okay, so these are all cases that we encountered with. I think I have done some justice to the topic. Thank you.